It's a very complex, complicated issue. There are a lot of problems which can arise in the heart team concept, but we have to go forward. To discuss these issues, I think we have the best possible people today. So I'll request Dr. Naresh Trehan to please start and give his views, and let us see what his views are about formation of cardiac team.
Good afternoon. So first, thank you for the organizers to give this opportunity. Second is homecoming from me because I spent 5 years in Lucknow, so SGPGI was not non-existent then, but it's great to be back. The concept of heart team, as you know, and especially I think it's more applicable to India than it is to even the West, is the fact today we stand faced with a lot of criticism. Fortunately, the surgeons are less so than the cardiologists, that unnecessary procedures are being done, unnecessary stenting is being done, and them being the gatekeepers, the accusations are more against them, and many of them have admitted on national TV also that it's advantageous for them to put a stent because they get 10,000 rupees at home at night. So there are many accusations. Some of them are true, some of them may be a little exaggerated, but what do we do about it? The basic thing is that we as doctors, we as cardiac surgeons, we as cardiologists have lost moral ground, and I think whatever we can do to actually recover that ground and lead the way to transparency in healthcare, I think we would have truly achieved our leadership, which we should have anyway, because cardiac surgeons do perform some of the most complicated feats in the medical field. So why do we need a heart team concept? So we know today, and this was also demonstrated, that today more and more complex care issues are coming up. There are new devices, there are new approaches, there are redos, there are bad ventricles, bad vessels. So all this stuff has actually piled up, so that given one person taking a decision globally on complex issues can lead to inadequate or inappropriate therapies if left alone. So if you go down the list, you'll see what I meant, and it just reinforces the issue that it's time that we actually get our act together. So you hear it all the time from your patients, what the cardiologists will say, कि चीर फाड़ नहीं करना है, हम उसको स्टेंट से ठीक कर देंगे, 2 दिन में आप घर चले जाओगे, 3 दिन में काम पे चले जाओगे. All that stuff goes on, which is irrelevant to the given situation that you are faced with. On the other hand, you know what we say. We say the counter also, frequently denigrating the stents and other stuff, and actually telling them some truths that yes, the risk of surgery is 1% or less. So there are half truths that we also tell. So then you say, what is the literature say about the concepts of our team? And Vijay just said there are many challenges to it. Yes, it's a complex subject. You need many challenges we'll have. But let's get to the end of it and see if we really think that we have a choice. So you know what happens is that just hold it. Can you hold it, please? Yeah, thank you. So you know that what does the current evidence say? The current evidence does say that there are unwarranted variations in the ratio of PCI and CABG. There is documentation which says there is inappropriate use of investigation and intervention, and also poor patient understanding of the rationale. So patient actually is a very important center point in it, and if we are saying that the patient doesn't understand, then again there is a deficiency in our the way we practice medicine. So if you stack up the evidence right now, you will say that as we were discussing earlier, when to do skeletonize, when not to do, when to do, why. So these issues are always alive in front of us because no two patients are the same. So these issues also come in on a daily basis to us about what I have enumerated here, especially low EF, diabetes, and viable coronary anatomy, how to establish these three things and then how to take a complex decision, I think again needs a participative methodology. So there are some straightforward situations where you say, and I'll go over what the literature and meta-analysis shows, but we know that there are situations where syntax score comes to our help, number of vessels that have to be done, presence of diabetes, presence of other complexities like renal failure and all, also do actually help us to decide which is a better modality for that given patient. So if we go forward, we say all these things put together, we must look at all of them, throw them on the table, and then come up with whatever our solution may be, and not being basically so biased that our bias overrides the guidelines of directed therapy. So these are slides which, well, you know, these cardiologists always try to look at this stuff, but it is inappropriate in a surgical meeting. But so what is the evidence that is actually participative in our debate? And one is the fact that how cardiologists present the benefits of percutaneous coronary intervention to a patient with stable angina. It says in taped interviews, benefits of PCI were accurate in 5% of the patients, but overstated in 48% of the patients. So you're saying this is like supposedly a well-documented, well-taped documentation of a cardiologist's view when he sees the patient in front of him, and he also sees the salivating opportunity to be able to blow up a stenosis. On the other hand, they said, okay, if you look at it, that when the recommendation was made for CABG, only 53% of the patients actually underwent. 34 went towards PCI. And when PCI was, this is by the cardiologist, when PCI was recommended, 94 went and got PCI done. So that means also in the communication, the stress on what actually is relevant to that patient was never made, and that is one of the vagaries that we have to live with, that the gatekeeper is somebody outside of the surgical field. So to keep all these things in mind, then I think that the evidence kept gathering that what was being said as the best therapy is PCI, that if you look at all the meta-analysis of the recent trials, the large ones, the syntax, especially syntax and freedom, the meta-analysis shows overwhelmingly that in the subset of patients, surgery is no question a better option for immediate and long term. And then we say the consideration that we want to do, we want to be fair to the cardiologist also. We can't be saying that you are actually overdoing it and you are taking away patients from the surgeon. That's not the way to actually argue this whole thing. So we are saying what I've enumerated here, whether it's coronary anatomy, clinical settings, coexisting conditions, patient-related factors, they all come together in our decision making. So actually, if you trace back, the concept of heart team came from syntax. Because syntax, if you look at the whole spectrum, they put all these variants into the basket and said, let's look at it, and what comes out of it basically says that these are the things that we need to keep into consideration. And who are the people who are best to take into consideration? So today, or like we said in India, it has started, actually it's been mandated in the US and Europe now that there has to be, for decision making, there has to be participative decision making. In India, it's not so today, but these are the things that we put together. So we started the heart team concept in Vedanta last year. And what we do have in a non-invasive, invasive, and surgeon take this whole decision on parallel. The whole history and the angiograms appear in all our offices. So you don't really have to move from your office. You don't have to go and waste time somewhere and say, oh, it's too time consuming. So that's not a challenge. The challenge is to find the honest answer to the patient. And if that patient was your relative, you'd very readily do it and not make any excuse that I'm too busy or there is too much time taken or stuff like that. So what we are saying is that today is the time to transform our own head into saying transparency, and I can assure you, will only be in the benefit of the surgeon. So surgeons should actually be pushing it. Most definitely, we should not be the reluctant brides. So we fill up this form and we all sign it, and then of course discuss with the patient, and these are the factors we actually weigh. So when we have these lower syntax or older age, frailty and so on and so forth, PCI goes, and when we have highest diabetes, poor ejection fraction, all those factors then go for surgery. So this is by agreement. We have all stood by that whatever the ultimate decision comes out, we will all support it because it has been thought through by everybody. So this is just to actually give the preliminary concepts, practice of the heart team approach, and these guidelines have been come out very clearly, and we should thank as surgeons the Syntac and the Freedom Trial, which really brought to bear what we really always felt, but we were left to the mercy of the cardiologist. So what happens in this heart team with guidelines that were developed? And they were developed joint cardiology and cardiac surgery. 25 members from 13 European countries were taken, and there were 9 non-interventionists, 8 interventionists, and 8 cardiac surgeons. So there was very even representation of very sort of mature and accomplished physicians from 3 different areas, and they came up with these guidelines. And if you look at up and down, 1 or 2 vessel disease without proximal LAD stenosis, class 1 for PCI and 2 for CAB. But then down the line, 2 vessels, left main, 3 vessel disease with syntax prolapse. All these things are favoring surgery. So like I said, thank God for these 2 trials. And I might propose here that as usual, we always depend on Western studies to actually translate to ourselves. So we are right now designing our own, an Indian trial, and I would urge, I will be reaching out to all of you to do our own syntax and freedom trial, 1,000 patients in each study. So if you would like to, I think that's with the direction we should go in to establish our own criteria, our own guidelines, because we don't know how our corporates behave. But my suspicion is that the evidence will come even stronger in favor of surgery because our vessels are not that amenable, and you always see some injury because there's diffuse disease, some injury to the distal and proximal end. If not the stent, the distal and proximal end are vulnerable to restenosis. So point is, ultimately, it's a collaborative effort. If you can, and you are in an institution, and we certainly are at Medanta, that we have a cohesive team. It is all one cardiovascular institute. There are no cardiologists, there are no surgery department. It's all one cardiovascular. So we have had a relatively easier time to introduce it and commitment to it. So I'll leave you this thought with you here. There are many slides, but I think this is enough. And hopefully we'll have a healthy debate on it. Thank you so much.
Thank you, sir. Thank you, sir. Dr. Trehan, you have told us about the very balanced view of the surgeons and the cardiologist. Now I will introduce you to the cardiologist. I am Dr. Satyen Tiwari, professor at SGPGI Lucknow. With me is another senior professor, Professor Dr. S.K. Dwivedi. He is a professor in cardiology department at King George's Medical University. With us is a very famous cardiologist we all know, doesn't need any introduction, is Dr. Shri Sriramath. He is from Pune. He has just came over for an hour for this meeting, and he is the president-elect and also next year president of the Cardiological Society of India. And I am honored to have you here, sir, among all the famous surgeons, and he will speak on the cardiologist point of view, what we think about this.
So I come from city of Pune, and good afternoon everybody. So So when we talk of heart team approach, firstly, thank you to the organizers for inviting me as a president of CSI in next year. It's my honor to be here, and I'm sure I will take this heart team concept, even while planning the scientific program, so that we all learn a lot from these concepts. So it's basically a tumor board which was giving better and better results dating back to 1960. And the heart team approach came 10 years back when we had syntax going. But in many other ways, we have always been practicing this. When we talk of heart team, we are talking of all things in decision making. But if you see a story, patient going from age 50 to age 80, having one or two procedures, all of us have been talking of patients, cardiologists and intervention cardiologists maybe together, and the surgeons. So one surgery, one angioplasty in 30 years, or one angioplasty and one surgery in 30 years. This is a very fancy vein graft, end joint to the side, coming back 10 years later with a critical stenosis. We call it man-made left main stented, and did well for another 10 years. This was another one where the lima is functioning, but critical disease in the left main area, giving two big size diagonal, and we asked the surgeon to come in, but the lima was stuck to the chest cage. The surgical mortality was considered to be very high, and we had to do kissing stenting here, came back with restenosis, and again we had to do another percutaneous intervention. 5 years, he's doing well. And we all know that once in a way we come with a stenosis in unknown area, like in subclavian area, which is producing ischemia. So all these kind of need togetherness, maybe it was spread over years. While in this case, the one previous angioplasty surgeon did a Y graft with radial 5 stent joint, 5 vessel joint here. And what happened was this portion of the graft was blocked, this portion of the graft was blocked, so we stented here, and thus got the vessels flowing. So it is partly using the surgical graft and now putting in some kind of stenting that we are able to revascularize this particular patients. So we have very trust level going down, and surgeon doesn't trust cardiologist. We have the court also not trusting us, so we have to face these kind of scenarios, and we truly have some situations where multiple approaches are going to be very effective. So what we are probably going to do with an improved patient satisfaction, like patient feels that yes, he has shown it to this doctor, he has shown it to that doctor, and all of them feel that this is going to be the option. And this is very, the Americans as well as Europeans are all going to mandate all this into our team. The teams are going to be quite different. Like for heart team, the team may be looking different. But if you take TAHAR, the imaging people will also come in. So it's going to be quite different from situation to situation. And we know there could be lots of gains and lots of disadvantages to both these techniques which you saw. But for somebody like this gentleman, already 48, we ended up putting 5 stents. This is 1 year post-angiogram doing well. This is not by choice. This is the patient forcing on us that he never wants to undergo bypass surgery. He was going from door to door for 1 year before we did all this and so on. So this is going to be a team approach in various areas, the coronary areas, the valvular and structural heart area, as well as the heart failure area. And we know that simple issues where you have a high syntax score, low surgical risk, no discussion, patient goes straight to surgery. The discussion is going to come only in the areas where we have like syntax score is around 22, it is going to be a high risk surgery, and then comes the discussion what to do. I'm surprised here in this slide that ostium and mid-shaft, these are actually ideal areas where stenting works. So this is probably one area, but yes, we can discuss it with the heart team and still accept angioplasty as a better modality. While we have syntax score, which is maybe less than 32, we can discuss with heart team. Left main bifurcation, again, maybe a surgically better addressed. So all these acute cases are actually interventionist area, not surgical area. They will remain like that. The appropriateness, I think this is something which we need to discuss. But when we talk of appropriateness, this is how it happened, that all these teams had more cardiologists and very few surgeons giving you the guidelines. So the appropriateness criteria were quite screwed up. And the surgical societies, this is actually David Taggart's comments, that the surgical societies should no longer provide a token surgeon on cardiology guidelines as they are hopelessly outgunned and ineffectual against what are in effect exclusively cardiology dictates. So we have to have something like this, which you already saw, that an equal distribution of surgeons who are thinking and equal distribution of cardiologists. So this actually, the complex CAD should be discussed by a heart team, class 1C indication, and then only they should go for surgery. Of course, the surgery must have an internal memory. I'm sure nobody operates without internal memory these days. But what is important is a completeness of revascularization. Only if your surgical revascularization is complete, you're going to be giving the justice. And this is what the European statistics say, that despite all this, you can see certain countries, like in Germany, the basic substrate is probably similar, and yet in certain areas there is a high PCI rate compared to surgery. And this is what we are talking about. The interpretation of this kind of data is the physician performing the diagnostic catheterization and treating hospitals are strong independent predictors of the way the patient will get revascularized. So for patient, cardiologist is the first contact. Cardiologist can try the way he wants. But this is what we are trying to say. In fact, this study, what the patient understands out of discussion with the cardiologist, only 1% when they came out from cardiologist came in accepted that he was told that it's a symptomatic relief, that's why they're doing an angioplasty. So it's very, very little. We know where surgery is going to be effective, but we must also understand the shortcomings of a surgery. And we also know that there is a kind of an attrition rate, graft occlusion, arterial graft occlusion. So the cardiologist used to say, restenosis only 6 months, but beyond 6 months, stents always function very well. But we know from a Japanese study that there is attrition rate for the stenting too. What we call as new atherosclerosis could be an attrition rate in the stenting. So when you talk of a natural history of a patient from birth to death, one procedure may or may not be enough. Like in this case, at age 38, we have done a right coronary angioplasty. At age 48, he comes with another acute episode with thrombolysis. So we have critical lesion here, occluded LAD. Patient goes for surgery. Wait, we can still do an angioplasty. So he gets an angioplasty to LAD and circumflex. He's only 48. So you people can wait for another 10 years before we can send this kind of patients for a surgical graft. This gentleman, 28 years, right coronary artery stenting. At age 42, he had these 2 stents. There was an aneurysm which was done with a covered stent, and he comes back with instant restenosis addressed, and he's now 49 years. What are you going to do with these kind of cases? I think one arterial revascularization may or may not be enough. So it's better to push, just as you yourself understand. Any patient who needs a valvular surgery, we try and push it as late as possible before we operate or before we do a balloon. So this is the first intervention cardiologist, and this is his substrate who had the angioplasty. And angioplasty has come a long way. The event rates related to angioplasty has gone on reducing it. And in 2003, we see just around 2 or 3% of the patients getting into some kind of procedures. Add to this the dissolvable, degradable stains, and you find that if you do a CT angiogram a few years later, you would find just two dots like this, otherwise a natural vessel. And this is how the technique has advanced, and what it has done is the difference between surgery and angioplasty, which was once upon a time 32%, came down to 14% with stents, and came down to around 2% with drug-eluting stents. So this is what we are talking, a comparison between surgery and angioplasty, and all are getting together. So we know syntax score, what it taught us, but what syntax did was it used a stent which was really 10, 12, 14 years old. We don't use that kind of stents anymore. So if you're to do a syntax study with new generation, today's stent, this is the difference between Taxus stent which was used and this is the new generation stent. I'm sure the angioplasty is also going to look reasonably good. And add to that newer technique like FFR. We know that FFR can be very effective in deciding. So this is an angioplasty done with FFR guidance. This is an angioplasty done with angio guidance. Clearly a difference. So use FFR, and this kind of FFR usage can actually downgrade the lesions. What you feel as 3-vessel disease can be 2-vessel disease once you do an FFR, and thus help you decide what is going to be the correct approach for given patient. So when you have patients who have high syntax score, you can clearly see that CABG can be an option, but use FFR. If it is less than 0.80, use PCI kind of technique. And this is how the guidelines are also changing. Things which were earlier considered to be 2A indications become 1B indications. So guidelines are also improving. And then we go to a hybrid cath lab. This is where I think the importance comes. Like you have a clearly surgical LAD and you have a moderate lesion in the right coronary artery. Will you also graft the right coronary artery? Do an FFR. In that case, if FFR is positive, stent the right coronary artery after you're done the Lima to LAD. So hybrid procedures, what it is going to do is going to give you an excellent results coming out of IMA and excellent result coming out of a drug-eluting stent. So it's going to be a combination of these two which is going to make a hybrid procedure more and more effective. And this actually brings us to TAVR, which is going to be a true, genuine combination. In any TAVR meeting you go, today you'll find if there are 10 people, 3 would be cardiac surgeons who are attending, trying to learn the percutaneous techniques. We know that once AS becomes symptomatic, it's a downhill course, and that is where you and I face most of our patients. AS who is symptomatically already going down, and then it's a steep course. So today, if you see TAVR data, you have high-risk patients getting better, intermediate risk patients already shown, and now TAVR is going studies where TAVR is given to average risk surgical patients, and we will soon know the results. And lastly, talking about heart failure, I think this is again an area where surgeon is going to sort of help us buy time, LVAD, before patients goes for transplant. So at this stage, we should not get over enthusiastic about this kind of approach. We must understand each other. We know what are your good points, what are my good points, and once we are able to get all these points together, we are probably going to look better, look best advice to the patients, and this is how the patient is going to live longer with coronary artery disease. Thank you indeed for your attention.
Thank you, Dr. Hiremat, for putting the things in perspective for cardiologist. The august audience has heard the views of both the surgeons as well as the cardiologist. Initially taking a warring position, both